Good afternoon. Actually, this was supposed to be a live in box. Initially, it was supposed to be a live from Pune, but for some technical reasons, we have to show it as more of a CD presentation. I bring with me compliments from my colleague, Dr. Chandrasekhar Makre, and my vascular surgeon, Dr. Danesh. This first case, we are beginning. But I want all of you to be involved in it. We are going to take gaps. We have enough time. And let me take questions and answers too as we go on. This was a 27-year-old lady, hypertension for 3 years. And as we are doing this case, her systolic pressures were 270 despite 3 antihypertensive medications. She was found to have Doppler, which said that there is a right stenosis. At this age, many times we do think of aortoarteritis as a possibility, a young Indian female. But all the parameters like CRP, the ESR were negative. A CT angio was done, which cleared all the other vessels like there was no disease of the aorta, no other involvement of any other vessel except the right renal artery. This is an aortogram for you. You can faintly see the right renal artery. You can make out that the kidney size on either side is quite normal. I will show you the next angio with a selective renal catheter. But before that, I must confess that we really struggled to get the right renal artery with an aortogram. Maybe we should have done with different settings. Maybe we should have done a DSA to show this. This is the lower, smaller renal artery, and you can see a small aneurysm, which is intrarenal. But otherwise, no narrowing, and this artery looks reasonably good to me. And this is the one which is the culprit, and when we inject in this artery, you can clearly see multiple aneurysms. What is also striking is between the multiple ectasia or aneurysm, you also see critical narrowings, and these narrowings are really tight. I guess everything focuses around this renal artery as a possibility for renal hypertension. And obviously, since I told you that this was a very difficult to treat hypertension, we should be doing something for this renal artery. So we all focus down onto an FMD. I'm sure any comments from the floor or from the stage, Michelle? I mean, we agree that this is FMD.
I agree with you. It's FMD.
And we know that FMD, the intervention from renal angle could be quite an important intervention. So many times FMDs are known to drop pressure even on table as we are doing the procedures. The trouble in this case was the sitting of the guide catheter was very difficult. So we thought we'll come in with a small diameter renal diagnostic catheter, wire the vessel, and then introduce the guide catheter. The whisper wire, most of us believe that is the most slippery wire and it should slip through. That was our contention, but see, the whisper wire was just looping inside the big aneurysms and would not make a forward entry. So we were kind of stuck trying to get a wire further down. So at this stage, we have a mother and child catheter, 2 catheters, 1 guide, 1 diagnostic through the guide. And we changed the wire. So we thought we will get rid of that and we'll come in with a Filter XT. Most of you agree that this is a 014 very slippery wire, hydrophilic wire. Many of us use it for CTO as a priority choice. And this wire made some progress. It went into fair distality, though of course it was again and again looping in the proximal portion. Why do you use a stiffer wire? We always worry about perforations related to this kind of wire. But I think we are in a reasonable location to go ahead. Any comments at this stage? Feel very free, otherwise live in box will lose its meaning. Anybody or Michelle, are we go on?
Yes, in that, yes, you balloon at that stage or not? You place a balloon over the wire just now?
Yeah,
Okay.
Now we are with a balloon.
Okay.
We first tried with a 2O balloon, and 2O balloon couldn't cross. So this is a 1.25 balloon. This is the only balloon which could go down. And with a balloon in place, we are able to advance the wire a little bit distally. I think most of us follow this kind of techniques that the balloon-supported advance of the wire. Again, you have to be very careful. But the wire was looping in the distal portion, and we thought it's reasonable to continue. So we did some aggressive dilatation with a 1.25 balloon to get a 2.0 balloon inside. So 2.0 long balloon dilatation. And then this was the scene that you continue to see the aneurysms. We have dilated the critical narrowed segment. The blood pressure at this stage dropped by almost 60 millimeters systolic. So from 270, we are looking around 210, 190 in that range. And we thought the obstruction to some extent has been sort of corrected. So at this stage, we have multiple thoughts. Any thoughts one would like to address? Anybody from the stage, maybe Dr. Yadav? Enough? We thought there was some degree of narrowing persistence, so we came in with a 5O balloon. The artery was about 7, and this was a low pressure inflation. You can actually see this is just about 3 or 4 dilatation we gave. Didn't really try to correct the mid portion of the narrowing. So this was a balloon again, 5 long balloons, single prolonged inflation, the way we do for balloon techniques when we do coronaries. And this was the result. So this, at this stage, her blood pressure had come down to 170 systolic. She was feeling quite good, though the procedure has been quite long. And we all know that for FMD, we could stop. But so should we stop here, leave the aneurysms as they are? What is going to be the future of the aneurysms? Anybody? Yeah. Can we get a mic for Dr.?
You have to do something for the aneurysm, otherwise it's going to become bigger. Okay, you're going to be in trouble.
Yeah, Dr. Khanna, this was an FMD. This is at the end of 1.5, 2.0, and 5.0 balloon dilatations. We see the aneurysms. So all of you agree that we need to do something for the aneurysms, or somebody wants to leave it as it is? Dr. Yadav feels that we are done and leave the aneurysms. So Sushil feels we should do it with covered stent. Pune thinking? All right, so yes.
I would say that Michel Henry may be able to give you some insight into that. I've seen him treat something like this with a multilayer flow modulator with very good result, actually.
I treated 2 aneurysms, 2 patients with aneurysm like that with multi-layer 2 with beautiful result, but that's the problem in India. But it's difficult to leave a patient like that with this aneurysm.
So clearly we are talking of 2 options. One is leave it as it is. We have done a lot of flow modulations. The aneurysms might subside, and the blood pressure is already showing a reasonable response. And the other is correct the aneurysms. I think these are the 2 thoughts that we have at this stage. Anybody has any third thoughts, any third thinking that we can think of? We in the lab felt that we should cover this with a covered stent, but on that particular day, we did not have the correct size covered stent. See, you have to imagine that you can't have too long a covered stent because you would occlude the distal bifurcation. And you need to have a covered stent which is coming back to the osseum. The other option could be just cover the portion which has a aneurysm with a covered stent and maybe use a regular stent at the osseum towards the aorta. That could have been an option. But that particular day, we had no covered stent, though we did discuss this amongst ourselves, and we thought we are looking reasonable. And maybe we'll check next morning as to how things are and wait for it. So we thought we'll stop, and the patient was looking reasonable, and look at what happens next morning. We just wanted to make sure what's happening the next day, and we bring her to the cath lab. We do an aortogram, we don't see anything, but this is with a diagnostic catheter, and we just can't see the renal artery. So all those who said that leave her alone, Dr. Yadav, you included, I think all of us were wrong that we couldn't have left her at this stage. So we really struggled to get another diagnostic catheter inside, and after a little bit of hunt, we are looking like this. This is a small diagnostic catheter. We see distal opacification, but clearly there have been multiple dissections along the length. I think you see, you can see hold-up of contrast, staining of the vessel wall, and we are clearly looking to have dissected the renal artery. So again, big effort required to cannulate with a wire dissected renal artery. But we had no option. So we decided to. No. On the second day, no, Dr. Yadav, on the second day, first thing we did an aortogram and we didn't see anything at all. Okay? So, no. I haven't brought the pigtail. So there's no chance of dissecting with pigtails. So
do you think?
Second day, yeah, this catheter might have dissected and caused because you have dilated with the balloon one day before, and that may have caused the dissection. And then this angio catheter, which has not done any harm that time, now it has done the harm.
Can I make a small comment? If you've ever managed any of these surgically, if you look at them, they look like a string of beads inside, and when you open them up, you open the vessel up and look at it, there are multiple septi and things that are all. The wall inside is looks like a washboard, like people wash their clothes on, and except that the ridges are very tall and very irregular, and I can see where if you ballooned that or dilated in any way, you could end up with some planes that lend themselves to dissection. That's why one of the reasons I would have left it be, I would have done something with it before. But if you didn't have a covered stent, I would have waited because I don't think you could. I don't think that putting a bare metal stent in there was the right thing to do. That I don't think is the right thing to do. So without a covered stent, I think you had no option except to go home and come back and look the next day, which I'm glad you did. And I'll bet that there was enough flow there to keep that kidney alive, that if you got in and fixed it, that it probably did well.
So, Dr.
Do
Yadav,
you think there are clots or not?
What?
Do you think there are clots, thrombus in the artery? No.
Clots could be secondary to the dissection and low flow.
Somewhat flow downwards.
So then was this catheter, and you feel that this catheter is dissected? Oh, it's too long, it's going all the way down.
Yeah, the catheter dissect like this will be like a spiral.
Unlikely, though we appreciate that at least you're thinking differently from many of us,
Yeah, what we feel, sir, by angiogram.
Anybody wants to support Dr. Yadav? I mean, since it's an open debate, we are...
I
Anybody feels that the catheter has dissected the renal artery? Dr. Yadav, no takers, unfortunately. So anyway, but you are thinking differently than us. Let's just go ahead. So this is what the guide catheter shows. We have proximal dissection, and that's extending almost to the bifurcation. I think some of the lower pole renal arteries are also not seen. Wiring is, of course, going to be very difficult. So we are back with coronary wires. The wire went reasonably easily into some distal vessel. Then we have second wire, just trying to get into some more vessels distally. That was the whole intention. We did low pressure balloon dilatations in this area, trying to see what is in the distal portion. And so this picture actually sort of suggests, Michelle, I don't think there are clots here. I mean, this looks more dissection than clots here. So,
Fibrinolysis thrombolysis option, no?
At this stage, you would have loved to go with thrombolysis? Okay.
No.
We didn't give, I mean...
what is your opinion?
I thought we are all dealing with dissection, and I would probably stay away from thrombolysis.
Yes, with the dissection with a stent, yes. But before treating with a stent, maybe I would have done thrombolysis, no?
Mm-hmm. Thrombolysis with streptokinase, or I mean, some kind of lytics, or just GP blockers?
Yes, why not?
Yeah. Can you take a mic? Somebody can give him a mic. Can we have a little light in the auditorium? I don't think we need to be so dark, you know. Can you just make arrangement? That's good. Thank you.
Yeah, that's good.
Okay, can you hear me, yeah?
Yeah, yeah.
Doing thrombolysis, don't you think you're sending clots into the kidney, which can cause infarction? Already, we can't see the lower pole of the kidney. There is a possibility small, clots can go into the kidney and further damage the kidney.
I'm not sure. I mean, you're putting so much of material like balloon and so much. I think they probably carry more clots into the distality compared
But thrombolysis, definitely, the small things will go and they'll end up, the end vessels. There is a high chance of infarction.
They would probably locally dissolve the clot. Let's move on. This is a low pressure 220 balloon dilatation. So we are clearly struggling with no flow where the first wire is. You have some flow where the lower wire is going. So at this stage, we needed to cover a fairly long length of the renal artery with stents. The distal stent will have to be regular stents because there are many side branches. So this is a 4 into 30 driver stent. We have, you can see the very tight waist as we went up. Somehow we had to use very high pressures here to get the waist off. So I don't know what kind of pathology we are dealing with, but maybe you would have an answer to why we needed so much resistance. So this first stent is deployed there, and at this stage we decided the back portion should be covered with a covered stent. By then we had procured 7 into 39 covered stent. So through the first deployed stent, we put a small baby catheter. Through the baby catheter, now we advanced a 3-5 wire. So we have changed from 014 system to 035 system. We pull out the baby catheter, and we are ready to take covered stent. Now this is a 7 into 39 atrium stent. which I was told will be compatible with 8 French guide. So we were with the 8 French renal guide, and unfortunately the atrium stent could not get in through the 8 French guide. Were we wrong, or we're right? So we had to sort of, I mean, it was not going just at the beginning of the guide catheter. So we decided we will send the stent bare, and so we removed the guide catheter. And you can see the stent come in, but the stent would not, this is not that stent, this is something else. So the covered stent could not take the bend into the renal artery. It was totally unsupported. It was on a 035 wire. That was the only good thing, that there was some support. But obviously it was not good enough to take the stent into the renal artery. So after a lot of manipulations, I think we had to give up that idea. And now we are with Genesis stent over the wire. Oh, I think the idea to exclude the aneurysm with covered. Oh, I wouldn't sort of trust.
Aneurysm is already how to close the aneurysm. You just make a flap, it will close. So aneurysm is already closed with the dissection flap. You just put the stent, bare metal stent, usual renal stent.
I think we were sort of preset in our thinking that we have to use a covered stent to cover the aneurysms. But anyway, I would still imagine, I mean, I agree with you that flaps may occasionally take care of the aneurysms, but you have to put a stent, so why not covered stent? You know, I mean, just look at, so this is the stent which was going partly into the renal artery, and we had to sort of take it back. So then we come back with the guide catheter, and this is the Genesis stent. We touch the already deployed stent. We deploy that. There is some area to be covered at the back, so we put in one more stent. See, mind you, this even with a high pressure non-compliant balloon, which you see there, we were not able to get the waste out completely. So this is Genesis 715 at the osseum, and again, very high pressure inflations. Look at the shape of the stent that you can see, you know, there is taken the shape of the aneurysm, and it has not expanded in the area which showed critical stenosis. So I guess this has something to do with the pathology of the FMD, and this is the final stent in the osseal position. The flows are clearly not good. I think Michel's thinking that we should have given some kind of lytics or used GP blockers looks very true at this stage. Maybe we could have improved the flows, but I don't think we gave any GP blockers. So this is how we ended up with 3 stents, bare metal stents, and a flow which was struggling. It's about more than 6 weeks, about 2 months complete. Her blood pressure stays around 170, kidney function is absolutely normal. So I would feel so far so good, and we don't see aneurysms even with bare metal stents. Mike, we will get a mic for Dr. Mike for you.
5 millimeter balloon, or whatever you have dilated in the initial, instead of dilating with the 5, you could have left there. It's a disease is similar like that. It's not identical. It's similar to that of the aortoarthritis. Aortoarthritis, it's again pain arthritis. Means it's a disease, fibromuscular disease involving intima, media, as well as the adventitia. So in this disease, I think you just dilated and left 2.5 or 3 millimeter balloon. Your aim is what? To create the lumen so that ischemia doesn't occur, blood pressure control. That's all. And whole thing has been created by, after dilatation with the 5 millimeter balloon, checking next day. I think that is it.
Checking next day I thought was important,
And
because
that is,
we would have all gone with the belief
because
that
you have
it's
done more
well.
harm than good next day.
I have a small comment and experience also. As Yadav said, it's the disease actually. Even if you would have put a covered stent on the day one, the result would have been the same because the radial strength of the stents which we are using, Genesis and others, when the radial strength is not that much to actually withstand the fibromuscular dysplasia, which is actually can actually collapse. A similar patient I had about 1 year back. I put it, and luckily I had a stent boost in my lab, so I could actually see the unexpanded portions or a unequal expansion. So I had put in another stent. I put 2 bare metal stents, and the result was good. Probably the radial strength is very important for this particular disease.
So the second stent was sort of get more metal.
Yes,
more
exactly,
metal
exactly. And post-dilatation is important. The aneurysms would not have mattered. I personally feel that if you had put even a covered stent on day one, the result would have been the same.
So we can't make a frame, we can't frame a right thing always. So what we have done is like,
The radial strength of stainless steel stents, which used to be there earlier.
don't put a stent.
Where?
Don't put a stent in fibromuscular dissection.
Yeah, that is what
Until the dissection is there. Widespread dissection is there. We don't.
Yeah, that's what our feeling was.
Sometimes we are using cutting balloon. That too very undersupplied.
All right. Should we go to
Otherwise,
the
good
next?
case.